I want to walk you through something specific. Do you have throat mucus that's worse in the morning than at any other point in the day? Does it get worse after meals, particularly larger ones, or ones that include coffee, alcohol, or acidic foods? Does it get worse when you lie down or recline? Do you sometimes wake up with a slightly bitter or sour taste in your mouth? Does your voice sound a little rough or hoarse in the morning and improve as the day goes on? If you said yes to 2 or more of those, your throat and your stomach may be connected in a way that nobody has clearly explained to you yet. Those are not random symptoms. They are the specific pattern that silent acid reflux produces in the throat of an adult over 60. And recognizing that pattern is the first step toward addressing the right cause, instead of spending more time and money on solutions that target the wrong one. Let's talk about what's actually happening. Quick but important, everything here is educational only, not medical advice. Acid reflux diagnosis requires evaluation by a qualified physician. Never self-diagnose or self-treat based on this video. Drop reflux in the comments for a free guide, the complete LPR symptom checklist, plus the questions to bring to your doctor. Here's the piece that most people are missing, and why this condition gets missed so consistently. There are 2 forms of acid reflux. Most people know one of them. Almost nobody knows the other. The first is classic gastroesophageal reflux disease, GERD. Stomach acid rises into the esophagus. The esophagus has some acid tolerance, but not unlimited tolerance, so after enough exposure, you feel it as heartburn, burning in the chest, discomfort behind the breastbone, the kind of symptoms that clearly point to the stomach. The second form is laryngopharyngeal reflux, LPR. In this version, stomach acid travels further, past the esophagus, through the upper esophageal sphincter, all the way to the throat, the voice box, and sometimes the nasal passages. And here's what makes it so consistently missed. The throat is dramatically more sensitive to acid than the esophagus. Even microscopic amounts of acid touching the throat tissue cause significant irritation, but often without producing any chest symptoms at all. No heartburn, no burning, nothing that points to the stomach, just throat symptoms that seem to have no obvious cause. The result is that millions of older Americans walk around with LPR, chronic acid reaching their throat every day, spending years treating allergy symptoms, post-nasal drip, and throat irritation, while the actual source of those symptoms sits completely unaddressed 1 level below. That's the gap this video closes, why LPR becomes significantly more common after 60. This isn't coincidence. There are 4 specific physiological changes that happen with age that make acid migration to the throat progressively more likely, and understanding them explains why this condition clusters so heavily in older adults. Change 1. Reduced lower esophageal sphincter tone. The lower esophageal sphincter is the muscular valve between the esophagus and the stomach. Its job is to open when you swallow and stay closed the rest of the time, keeping stomach contents where they belong. With age, the resting tone of this valve gradually decreases. It doesn't fail dramatically. It just becomes slightly less reliable, particularly during sleep, when all muscles relax, and after large meals, when stomach pressure increases. That reduced reliability is enough. Even occasional, brief openings of that valve during sleep allow acid to begin its migration upward. Change 2. Reduced upper esophageal sphincter tone. The upper esophageal sphincter is the valve between the esophagus and the throat. This one is the last line of defense before acid reaches the larynx and pharynx, and it too loses tone with age. A younger upper sphincter would intercept most of the acid that gets past the lower valve. An older one lets more through, which is why LPR becomes more prevalent specifically after 60, even in people who had no reflux issues at all in their 40s and 50s. Change 3. Slower stomach emptying. The stomach empties more slowly after 60. That means food and acid remain in the stomach for longer periods before moving to the small intestine. Longer retention time means more opportunity for acid migration during the hours after a meal, and more acid available to migrate during sleep when the last meal of the day may still be partially present in the stomach. Change 4. Increased time spent horizontal. Older adults statistically spend more time lying down or reclined, whether due to rest, sleep duration, afternoon naps, or simply more reclined leisure time. Every hour spent horizontal is an hour during which gravity is no longer helping keep stomach acid where it belongs. The combination of reduced sphincter tone and increased horizontal time creates conditions that are significantly more favorable to acid migration than at any earlier point in life. These 4 changes don't have to all be severe to matter. Their cumulative effect, working together every day, every night, is what produces the chronic low-level acid exposure to the throat that drives persistent mucus production. The complete LPR symptom picture, or beyond just throat mucus. Throat mucus and the need to clear are the most common presenting symptoms of LPR, but they're part of a broader pattern that, when recognized as a cluster, makes the diagnosis significantly more identifiable. Morning hoarseness that improves through the day. During sleep, acid reaches the vocal cords and causes mild swelling and irritation. The voice sounds rough or strained in the first hour after waking. As the day goes on and the vocal cords have time to recover and hydrate, the hoarseness gradually improves. This morning-specific voice change is one of the most distinctive features of LPR and one of the most commonly dismissed as just getting older. The globus sensation, the feeling of something stuck in the throat. Many people with LPR describe a persistent sensation of a lump or something sitting at the back of the throat that they can never quite clear. It's not actually a lump. It's chronic low-grade swelling of the throat tissue in response to repeated acid exposure. The sensation fluctuates, worse in the morning, often better mid-afternoon, potentially worse again after evening meals. Chronic cough without an obvious respiratory cause. Acid touching the larynx triggers a protective cough reflex. When that exposure is chronic and low level, the cough reflex activates repeatedly throughout the day in response to amounts of acid too small to feel as heartburn. Many people with this symptom have been evaluated for asthma, for post-nasal drip, even for cardiac causes, without anyone connecting the cough to the stomach. Difficulty swallowing, particularly with dry foods or large pieces. Chronic acid irritation of the throat can cause mild swelling that makes the passage of food feel slightly rough or effortful. This is different from true dysphagia, the serious swallowing difficulty that requires urgent evaluation. LPR-related swallowing changes are typically mild, intermittent, and position-dependent. Any progressive difficulty swallowing should be evaluated promptly by a physician. Bitter or sour taste in the mouth, particularly in the morning. This is one of the clearest direct signals that acid is reaching above the esophagus during sleep. It's the taste of stomach contents that have traveled far enough to reach the back of the mouth or throat. Many people dismiss it as morning breath or dry mouth and never report it to their doctor. Frequent burping or throat clearing after meals. Both represent the body's attempt to manage excess gas and acid pressure in the upper digestive tract. When they occur consistently after specific foods or after lying down, they're pointing directly at a reflux mechanism. If you have 3 or more of these symptoms in addition to throat mucus, the probability that LPR is a significant contributor to your symptoms is high enough to warrant a specific conversation with your doctor about evaluation, the foods and beverages that trigger LPR most reliably, and why. Understanding the trigger list for LPR requires understanding one mechanism. Almost every food and beverage on this list does one of 2 things. It relaxes the lower esophageal sphincter, making acid migration more likely, or it directly irritates the already sensitive throat tissue when acid carrying its compounds reaches there. Coffee. Even in people who don't experience heartburn from coffee, the methylxanthines in coffee, theophylline and theobromine, are well-documented lower esophageal sphincter relaxants. A morning cup of coffee on an empty stomach, consumed in the upright position, is less problematic than a second cup after lunch consumed while reclined on the couch. Timing and position matter as much as quantity. Alcohol. Alcohol relaxes smooth muscle throughout the body, including the esophageal sphincter. Even moderate alcohol consumption in the evening measurably increases nighttime acid migration. For people with LPR, Evening alcohol consumption is one of the most consistent predictors of next morning throat symptoms. Acidic foods, tomatoes, citrus, vinegar-based foods, these don't cause acid reflux. The stomach's acid is already far more acidic than any food. But when acid-carrying compounds from these foods reaches the already irritated throat tissue, those compounds add a layer of direct chemical irritation that amplifies the throat's mucus response. Large meals regardless of content. Volume is a trigger independent of content. A large meal increases intragastric pressure, the pressure inside the stomach, which pushes against the lower esophageal sphincter from below. The larger the meal, the greater the pressure, the more likely acid migration becomes. This is why timing matters as much as content. The same meal eaten as two smaller servings, 2 hours apart, produces significantly less sphincter pressure than eaten at once. Mint and peppermint, a consistent and frequently overlooked LPR trigger. Mint compounds are potent lower esophageal sphincter relaxants. Peppermint tea, which many people drink specifically because it seems soothing, is actually one of the worst choices for anyone with LPR. The cooling sensation feels calming. The sphincter relaxing effect is working in the opposite direction. Chocolate contains theobromine, the same sphincter relaxing compound as coffee, in significant concentrations. Evening chocolate consumption before bed is a reliable LPR trigger in susceptible individuals. Carbonated beverages, including sparkling water. The carbonation increases intragastric pressure directly. Even sparkling water, with no acid content, no caffeine, no alcohol, can worsen LPR symptoms through the pressure mechanism alone. What actually makes a difference? The evidence-based approach to LPR management. Before anything else, LPR requires a physician's evaluation for proper diagnosis and management. Everything that follows represents lifestyle modifications that have evidence behind them and that are worth discussing with your doctor as part of a comprehensive approach. They are not a substitute for medical evaluation. The most impactful single change, bed elevation plus left side sleeping. We covered this in the second video in this series. It bears repeating specifically in the LPR context because the research on this is remarkably consistent. Elevating the head end of the bed frame, not just adding pillows, but actual elevation of the frame, by 4 to 6 inches, reduces nighttime acid exposure to the throat measurably. Combining that with left side sleeping, which uses the stomach's anatomy to keep contents away from the esophageal valve, produces an additive effect. Together, these two positional changes address the nighttime mechanism that is responsible for the morning heavy symptom pattern that so many LPR sufferers experience. The 3-hour pre-sleep eating window. Finishing the last meal or significant snack at least 3 hours before lying down allows the stomach to empty substantially before the body is horizontal. At 3 hours, the volume of gastric contents available to migrate is significantly lower than at 1 or 2 hours. This single time-based change, without any modification to what is eaten, has measurable effects on nighttime acid exposure. Meal size reduction, the same food, smaller portions. As discussed in the trigger section, volume is an independent reflux trigger. Distributing the same total food intake across more, smaller meals throughout the day, rather than concentrating it in 2 or 3 large ones, reduces the intragastric pressure peaks that drive acid migration. This doesn't require dietary restriction, it requires redistribution, identifying and reducing personal trigger foods. The trigger list we covered is a starting point, but LPR triggers are significantly individual. The most reliable way to identify personal triggers is a 2-week food and symptom diary, recording what was eaten, when, how large the meal was, and what the throat symptoms were like in the following hours. Patterns emerge within 2 weeks in most people that are more specific and more actionable than any generic trigger list. Voice hygiene during symptom flares. When LPR is active, when the throat is experiencing ongoing acid irritation, the vocal demands on the throat should be temporarily reduced. Prolonged talking, speaking in noisy environments, and anything requiring vocal strain adds mechanical irritation to a tissue that is already chemically irritated. Combining acid exposure with vocal strain amplifies the inflammatory response and slows recovery. Brief vocal rest periods during flares, combined with increased hydration, are a practical management strategy that most people with LPR have never been specifically advised to use. The conversation to have with your doctor. If the symptom pattern we've described today matches your experience, bring these specific elements to your next appointment. First, describe your symptoms using the specific terms, not just, "I have mucus in my throat." Say, "I have chronic throat mucus that is worse in the morning, worsens after meals and when I lie down, and is sometimes accompanied by morning hoarseness and a sensation of something stuck in my throat." That specific description points directly at LPR rather than at the generic throat mucus presentation that might lead to another antihistamine prescription. Second, ask specifically about laryngopharyngeal reflux, not just acid reflux or GERD, LPR. Because the management of LPR has specific differences from the management of GERD, particularly around dietary triggers and positional interventions, it is worth naming the condition specifically so that the conversation addresses the right diagnosis. Third, ask about evaluation options. LPR can be evaluated through laryngoscopy, a direct visual examination of the throat and voice box that can show the characteristic signs of acid irritation, as well as through impedance, pH testing that can directly measure acid reaching the throat level. Your doctor can determine which evaluation is appropriate for your specific situation. Fourth, bring your current medication list. As we covered in the previous video in this series, certain medications affect both acid production and esophageal sphincter tone. Having that complete picture available makes the conversation significantly more productive. The connection between your stomach and your throat is real, it's specific, and it's one of the most consistently overlooked causes of chronic throat symptoms in adults over 60. Not because doctors don't know about it, but because the symptoms point in one direction while the cause lives in another. You now have the complete picture, the mechanism, the symptom pattern, the triggers, the management approaches, and the specific conversation to bring to your doctor. Drop reflux in the comments for the free guide. And if someone you know has been dealing with chronic throat symptoms that nothing seems to fully resolve, share this with them, because the right explanation changes everything. See you in the next one.